Hi, it's Andrew Barrett again at ProLines Orthopedics. I'm going to start to talk about meniscus. Meniscus surgery, meniscus injuries. It's obviously a big topic. Hear about it all the time in the news, and probably have had friends or yourself dealing with this. So probably in knee surgery, one of the actually most confusing topics that we deal with. The meniscus can either be a life-altering injury, or it can be completely irrelevant and not worth discussing. So we're going to get into, over the course of a few videos, some nitty-gritty, some very specific details. This video is an overview talking about the meniscus, and again, my general concept is education on this topic. If you're dealing with this or someone you know is dealing with this, it's very important to understand why you have this injury, what's wrong, and why we have certain options available. So I'm going to talk a little bit about the anatomy and how these injuries occur. So first, looking at the model, this is looking at the knee from the front. This is the kneecap. We can move that to the side, look inside the knee joint, and what we see is these little rings. These rings are representing the meniscus. There's an inner meniscus that we call medial, and an outer meniscus that we call lateral. They're actually very different, but function relatively similar. The end of the femur is curved, the top of the tibia is flat, and there's a nice little buffer, which is the meniscus, to kind of cradle the end of that femur to make that help spread out the forces there. Otherwise, it would just be a convex or a concave surface on a relatively flat surface, and this helps spread out the force. So the way the meniscus is oriented is that it's connected in the front and connected in the back. So they make two C-shaped type structures in the knee. And as the knee moves, the meniscus, and we'll see in a video shortly, the meniscus is flexible. It moves with the knee joint. The outer side, lateral, much more so than the inner side or medial, because the medial is attached to some strong capsule in the MCL on the inner side of the knee joint. But that's the general structure of the knee and what it does when we're looking at a knee model. So let's look at a few slides here. So looking at the meniscus, we're going to again look at an MRI, a lot of MRI images. That's frankly a lot of my life is looking at those. And then we have a picture over here on the left-hand side. What we see is the attachment of the meniscus, the inner meniscus, remember the fibula bones on the outer side. So the inner meniscus attaches in the front, attaches in the back, and makes this hoop, okay? That lateral meniscus or outer meniscus does the same thing. And what's critical that we'll learn when we see some of these injuries is that this whole structure is attached from the front to the back, because that's what can resist the forces. If we walk and we put forces down onto the knee joint, we need them to be the meniscus to be attached to be able to resist those forces. So looking from the front on the MRI, what we're going to see is the cross section. So this MRI, here's the inner side of the knee joint and the outer side. So we're looking at across the knee joint. So we see the meniscus on the outside, it's thick and goes towards the thin, making a little wedge. Same thing here, thick on the outside, going towards the inner side of the knee joint, which makes a nice little wedge there. So that's what an MRI looks like when we're looking at someone from the front. From the outer side, what we're doing is looking as if the plane is this direction. So it's thick here, going towards thin in the joint, and then thin in the back here. So again, what we see when we look at the meniscus on the MRI are these two little wedges, okay? Now the outer side of the meniscus, you can really see how important it is, because the curvature of the top of the tibia is convex and convex on the end of the femur, and the combo of those two really make this meniscus important to help cradle the cartilage there on the end of the femur. So this is what an MRI looks like. Now, when we look at a video, what we're going to see is here's the outer side of the knee, and we're going to see this is the meniscus and how flexible it is. It's going to really come back and come forward here on the outer side of the knee joint. The inner meniscus does a little bit back and forth, but since it's attached here over to the MCL, it's much more static, and the outer side moves a lot more. So let's see if this will play here. So we can see that outer meniscus go back, go forward, move with the knee joint a lot more than this side. But both of them, it's required that they're attached to the back. But you can imagine that's having that flexible substance in the knee joint when we're doing athletics is how we often get these tears, because it's got to move along with the knee joint. So a big thing that a lot of people have heard about when they come into my clinic and are already educated on this is the meniscus. The reason we struggle sometimes to get meniscus to heal is that the blood supply is not very good. I always make the analogy, it's like cutting your skin versus cutting your fingernail. Cut your skin, put a stitch, it's going to heal up. Cut your fingernail, you got to either just trim it or wait for it to grow off or grow out. The meniscus doesn't have great blood supply. Even in its best part, it doesn't have great blood supply. You can see on the picture on the right-hand side, the arteries that feed the meniscus come in from outside the joint. And here's that wedge that we just looked at of the meniscus. And you can see there's some blood supply towards the outer side, and it starts to diminish and eventually getting to where there's absolutely none in this whole front area right here. No blood supply, so no capacity to heal. That's why some people have heard these terms, red zone, white zone. Essentially, if you have a tear in the, you can't really see this, but in the red zone, often those are going to heal nicely because we have blood supply on both the torn side and the side left behind. As you get to the red-white zone, it gets a little bit more tricky because only the back end, the part that's not torn, has blood supply. So getting those to heal becomes a little tricky. And then the white zone, pretty much very little capacity to heal. So sometimes we might not be able to fix a meniscus. It's not lack of trying or lack of technology or lack of techniques. Ultimately, when we stitch a meniscus, we need blood supply to come in there and heal that meniscus. The stitches only last for so long. So if you have an injury that doesn't involve an area that has blood supply, then probably just trimming it out has to be the answer. So if you look at the time of surgery, this is medial or the inner side, and this is lateral. If we look here, it's the meniscus on the inner side is attached in the back. It's attached around the front where we can't really see. And what we can see is perfectly good cartilage. That's all this white. And then the meniscus that makes that hoop around the knee. Same thing on the outer side, this hoop. What we don't see here in a perfectly normal, young, healthy knee is no flaps. The meniscus isn't unstable. It's just sitting there nicely protecting the cartilage. But you do see that it's white. Things when we do arthroscopy, when we look inside of any part of the body, we'll see red if it has blood supply. And the cartilage and the meniscus don't have great blood supply, and so that's why it looks awfully white at the time of surgery. So meniscus can tear in a few different ways. We sort of classify these as traumatic versus degenerative. So traumatic tears often happen with an injury, maybe an ACL tear or just a pivoting injury, a basketball injury, where the meniscus was normal before, sustained an injury, and now it's torn. These are often unstable. They can be disabling to the knee. Your knee does no longer function appropriately, and these are often surgical. These are the type that we like to stitch up if possible, sometimes just clean up, but generally treat those surgically if they're bothering the patient. Degenerative type of tears, on the other hand, are associated with arthritis, with wear of the joint. These are usually complex, bead-up tears, and we'll talk about those, but it's because of the arthritic process. These are generally non-surgical because at the time that these are happening, what we have is more of a problem with the arthritis causing the pain than actually the meniscus. They're often non-surgical and ignored. So again, looking at a meniscus, remember we just saw this normal meniscus. We want to see this wedge. We want to see it going way out to the capsule on both sides. Just kind of, I think of it as boring. We just want boring is good for the meniscus. When we start to see tears, this is what we see. This is a tear that's classic with an ACL. If you've watched the ACL talks, we've talked about the bone bruise pattern that we often see, but what we're now focusing on is this outer meniscus. And instead of boring, what we see is a meniscus here, part of the meniscus here, and then a line through them. And that line is the meniscus tear. So that is the unstable area. And this is more the red zone that we just learned about because there's blood supply on both sides. This would be a very repairable type of tear. Here's a different type of tear that's a displaced flap. So now we're looking at the front of the knee, and again, it's not boring. Something's going on here. If we look at the zoomed in portion, what we see is the top part of the meniscus looks right, but we don't see that wedge. What's going on? Well, the meniscus is actually flipped. There's a torn piece and it's flipped outside the joint right there. Here's the MCL in this knee, and so that it actually gets stuck between the edge of the bone of the tibia and the MCL right here, and gets compressed right there. This is what we would call a displaced flap. These are some of the most rewarding to take care of because we just unflip that, clean that piece up, and people generally do very well very quickly. So these are just generally what a couple MRIs look like of a meniscus. We have 3 planes that we can look at. What we call axial is going down the leg, coronal and sagittal. So we look at the meniscus in 3 different planes to be able to turn 2-dimensional objects into 3-dimensional structures in our head to be able to best identify the injury type and see what we can do about it. So there's a lot of classified injury types of the meniscus, some that we'll talk about, but just generally speaking, what you see here is there's a lot of ways to tear a meniscus, some of which are surgical, some not, some can be repaired, some aren't. It depends on the location, how bad the tear is, and some other factors like that. So here are a couple of examples. This is the lady that had the meniscus tear associated with that ACL, what we'd call peripheral tear. If we looked at it on the picture down here, what we see is that there's a vertical split separating the meniscus. In her situation, it would be back towards the back of the knee, but the concept's the same. And we can see that here. Instead of boring, we see that this front piece of the meniscus here is separated from the back piece. This would be in the red zone and very repairable. We can put some stitches in there to hold that all back together. And the way the stitches work is if you have the piece and the tear looks like this, the stitches enter in the top, come down, exit out the bottom, and then we tie it on the other side here to pull those together. Ultimately, we just need to pull the meniscus together until the blood supply kicks in and starts healing those. So this would be a peripheral type of tear. A bucket handle tear is a unique type where the tear is so extensive that the piece can actually flip. It's called a bucket handle, like the top of a pail, where that handle can go onto either side. So in this situation, we should see this meniscus way to the back of the knee, but now it's actually in front of this condyle. So the back of the meniscus is in front of the end of the femur here, which means this whole piece is pulled off. It should be way in the back of the knee. These are very repairable type of tears. There's a big piece of meniscus that we can suture through, and generally in a very vascular area. So again, we put a bunch of sutures in the knee, hold this back to the capsule there, tie those over the capsule. This is common with meniscus tears or pivoting injury, common with ACL tears or pivoting injuries to the knee, but again, a very repairable type. Now, a more complicated type of meniscus is a radial tear. So again, this picture doesn't exactly do it justice. If the tear goes all the way through, this is a very substantial injury because, again, we talked about the hoop stresses. The meniscus needs to be attached in the front, attached in the back, and those two need to be connected around. And if there's a split all the way across it, that's challenging because as you step, it wants to splay those apart. So what we can see when we look in the back of the meniscus is here's the end, or the back of the knee. Here's the end of one side of the meniscus, and here's the part that's attached down to the bone going up this way, and it's split all the way through. These are very, very difficult tears because a lot of the tear is in the red, white, or white, white zone. Because if you look in this situation, the meniscus would look like this, attached here, and the meniscus is splitting right along right there. So this part might be good to heal, but this part is kind of challenging. But that's all we have to repair, so we repair it all together. The way that we do this is by putting in some rip-stop stitches, which prevents these sutures from tearing out and pull it together, because otherwise these sutures, if we just put these long sutures in here, they would want to pull out of the meniscus. So we put these vertical sutures in first to stop that from happening, and then pull it together with these secondary stitches. But again, this is white, white zone, red, white zone, red zone back in here. So we fixed the whole tear in this situation. We have to be very cautious with the rehab, not let them weight bear immediately afterwards, really slow with the rehab because of the complexity of these type of tears. Then there's tears that just aren't repairable. Again, not by, as I tell people, I can put a stitch in anything, but you don't want to stitch in something if it's not going to heal. In this situation, you just have this big flap, this flap of the meniscus. Otherwise, healthy cartilage, the rest of the meniscus looks good. Just go suck out that piece of meniscus. Here's afterwards, and you can see, yeah, a little meniscus missing from here. But the number one goal of this surgery is leave everything good alone. So don't even touch any of the other stuff. Like we can see here, we left all of this normal meniscus here, just the little torn flap there, and much better. Here is another degenerative type of tear. You can see all this sort of junk torn tissue here, a little flap in the back of the knee. What are we going to do with this? This is not something you put stitches in. These are all tiny degenerative, non-vascular, white zone tears. All we do is we go clean that out. And again, don't touch any of the good stuff. We leave all the good stuff. So yes, again, there's, you know, how much we take out is dictated by how much is torn. There's a little bit of missing meniscus, but the majority is left intact there. These are some of the most satisfying here, which are these big flaps. Sometimes those, like that MRI we looked at where the piece is stuck down outside the knee, those are really bothersome to patients because they're in an area where there's not supposed to be anything. They're stuck outside the joint. It's like having something stuck in your teeth that you just want to get out. So these ones are really easy. We just take that piece out. Yes, again, a little bit of a defect, but these people are almost instantly better. It's like resolving their symptoms immediately. And again, leave everything good alone. So those are the type of tears that often do well with surgery, either repair or a little clean out. Now, there are another whole type of tears which cause a ton of confusion that I would like to just talk about for a second. Tears associated with arthritis. So when we have a normal knee, let's look at a normal knee MRI, normal knee x-ray again real fast. So this space here is the normal knee. That's where the cartilage and meniscus live. This is why when you look at an MRI, what you see is the cartilage and the meniscus lives between there in the cartilage. Now, look at an arthritic knee. Compare an arthritic knee, bone on bone, versus good cartilage knee. Well, the meniscus is supposed to sit in there. That's the home of the meniscus if we drew it on the other side. So the meniscus has to tear to get out of the way. It either gets pushed up and scrunched up over here or just gets shredded away. So when this patient comes in saying, I have a meniscus tear, I got an MRI, first of all, don't get an MRI on these patients. We know their problem is arthritis. And I can guarantee 100% of them will have a meniscus tear because it would be impossible for these two bones to touch, invading the space where the meniscus should be without having that meniscus tear to get out of the way. So these are the type that we don't treat surgically. Scoping a knee to clean up this meniscus will only make this person worse. But we see this a lot in clinic. So recovery real fast on repairs. Repairs are very different than what we call a meniscectomy where we clean it up. Because you saw in that video, as you flex deep, it stresses that meniscus. So for the first 6 weeks, we avoid deep flexion, usually only to 90 degrees. Get them into get patients into physical therapy to work on their quads, work on getting the knee moving again. By 3 months, we want full motion, but still not like a body weight deep squat, past 90 deep squats. Impact twisting activities, that's more 5-6 months when we return to sports. General surgery information, those take about 45 minutes to an hour. They're all outpatient, you go home the same day. Generally weight bearing, but in certain cases we have to restrict the weight bearing, not make someone non-weight bearing for 6 weeks. Those are the type of tears like the one that I showed, that's the radial tear where the two sides are separated, because if you go and step on that, it's going to want to pull right apart. And then a meniscectomy, this is where we clean it up. Generally, I'll be honest, most people are more sore and inflamed after this operation than they expect. And you can see what we do in surgery. All it is clean up, like I show here, 30-minute or less surgery. Just clean up that torn part, don't touch anything else, and yet still, as I say, we kind of kick the hornet's nest. We flare up the knee a little bit. So expect some swelling, but no braces, no crutches are needed. Usually between 6 weeks and 3 months, full sports. But I always have the caveat that the recovery is variable based on many factors. If you have some arthritis, or if you have a cartilage injury, or you have some other problem along with this meniscus, and we're only fixing the meniscus, the recovery might be a bit slower. Still an outpatient, or definitely an outpatient surgery. This is one of the very quick surgeries that we do in our surgery center. So that's the general overview of the meniscus. Again, very complicated injury, because sometimes it's no big deal and sometimes it's life-changing, and it's very hard. It takes us looking at the MRI, all three views, to really get a sense of how it's torn to best counsel you. Just make sure you find someone who actually cares about trying to fix them. When they are fixable, fix it. There's a lot of people that just kind of clean up every meniscus that they see instead of trying to repair it. We have very good techniques for this. There's modern, good suture techniques for fixing all of these type of tears. And sometimes we just need a cleanup, but now you know why. It's because of the blood supply. It's not our choice not to fix it. It's just some tears just need a little cleanup. But anyway, I'd always be happy to help you out if you need. Otherwise, I hope this was educational, just to learn about the problem and better get you understanding the problem might be going on with your knee. Thanks for watching.